Welcome everyone to this session. I see that a number of Kenyans have equally joined this session today. I hope you can see my slides now. We are very excited as Amref and Amref International University to start this collaboration with GLOHRA. We see this as an opportunity to learn together and to exchange knowledge, experiences for the betterment of global health. So for us, this is a very exciting opportunity. And I'm glad that we are also getting an opportunity to speak at the World Summit. And I look forward to meeting some of you, for those of you who are coming, as Esther said, that we'll be speaking there. My session today is basically an introduction to the next session and really allowing us to understand what we do and what Amref is doing in primary healthcare. So this is why my session is titled Advancing Primary Healthcare Research, Insights from Amref International University. So before I go into my session, for those of you who are not from Kenya, if you can just tell us, what do you know about Kenya? Because that is where we want to start from. Kenyans who are here, please don't answer that question. So this is my first slide. I've provided there some quick background about Kenya, where Amref International University is, and that is where we are regulated, but also the headquarters of Amref Health Africa is based in Kenya. So you can see our location from the world map. Kenya is located in East Africa. I hope you are able to get that right. The other thing about Kenya is we have a population of around 55 million, and the life expectancy in the current statistics is 67 million. I put some good things about Kenya there. We are known for athletics. I hope you are able to pick that as well. And we have just concluded the World Health Championship for those of you who are interested in sport. And we pride ourselves that in the world, we were able to be number 2, just behind the United States. So that is what we are socially, but it's also an important aspect to remember, because sports is an important aspect of health. I don't know, my slides are frozen. I want to go to... So my session is going to be titled Primary Healthcare, Advancing Primary Healthcare. And I want to start by telling us that Amref Health Africa is an organization that has been in existence since 1957, and it started as a flying doctor's service. Then you can imagine what was happening in 1957. We didn't have health services in many rural areas or in many parts of Africa. So these doctors were flying to the villages and providing healthcare, treating minor illnesses, and even evacuating. Today, the organization has expanded. You can see the map of Africa there. We have expanded. We are in so many African countries. So Amref Health Africa has got programs in primary healthcare in all the green. If you can recognize the countries in the green, of course, Kenya being the headquarters. So we are in Southern Sudan, Ethiopia, Tanzania, Uganda, Zambia, all those countries. The yellow represents countries where the organizations has got programs presence. So you can see that our presence in Africa is quite big. And our presence in Africa has been implementing work in primary healthcare. Hence, our vision is lasting health change. So some of the greatest achievements Amref can talk about is we've done a lot of work in reproductive maternal health. Even during COVID, we administered between almost 21 million doses. So that is the work of the NGO that has founded the university that is focused on primary healthcare. I want to talk about what exactly does primary healthcare means, because I know if you are coming from the global south, it means something different to you. For us, this definition of primary healthcare means a lot, because if you can see, this definition is talking about essential healthcare that is made universally accessible to individuals, acceptable through their full participation at a cost that they can afford. These keywords are very essential, are very important in many African countries, because this is the first care that is provided to really prevent disease. So as an organization, and even as a university, we believe that the greatest health change will happen if healthcare is provided at the lowest level. And I'm going to talk about the lowest level and some of the life savings interventions that are so critical to primary healthcare. When we say universally accessible, it means that everybody should be able to access. But the other key word there is acceptable, and in the full participation and the cost that you can afford. If you come from our countries, healthcare is always not free. The other thing that I want to bring into this discussion is universal health coverage. Universal health coverage is what our governments are working towards. We are talking about healthcare being affordable, accessible, acceptable, and available, and high quality for all Kenyans. So we feel, we believe that to achieve primary healthcare or to achieve universal health coverage, primary healthcare then becomes the most cost-efficient and cost-effective way to organize a health system. I'm going to talk about how does a health system looks like in Kenya. This is generally the structure of a health system in Kenya. We are talking about the first level is the community level. This is level 1, where there is no health post. We only have what we call community units. And I'm going to expand this in a bit more detail in this lecture today, or in this seminar. So at the community level, this is where you have the household. This is where you have the individuals. These are the people who must access and attain health at a cost that they can afford. The next level is what we call the dispensary or the private clinic. That is what we call level 2. This is where we now have a health facility with most of the time, you just have one nurse and sometimes a public health technician. Level 3 is what we call a health center in our setting, whereby we have a health facility that is a bit more established. with what other countries may call an assistant doctor. In our setting, we call them a clinical officer. This is somebody with 3-year training, and they are able to provide clinical services. Then we have nurses, but importantly, at level 3, many times you will have a maternity wing where you have safe delivery. And level 4, where you have an established hospital or a nursing home. So the highlight of level 1 to level 4 becomes what we call the primary healthcare systems, that for us, if we invest in this is where we can attain health at the most efficient way. So I want to dig deeper into these health systems. So what we call level 1, which is the community health unit, a community health unit, sorry, is composed of approximately 5,000 people or 1,000 households, and it is normally served by approximately 10 community health workers or community health volunteers. They used to be called community health volunteers, but I want to acknowledge the Kenyan government because they now are called community health promoters. So who is a community health promoter? A community health promoter is a member of the community. This is, they can be just your neighbor. They are at the community level. They could be running their shop. They could be running their just normal life. But they do volunteer, and they have undergone through some training as a community health worker. So they are not a formally trained healthcare worker. These are members of communities that have gone through a training, either 1 week, 2 week in form of a seminar. But what I want to say, in Kenya, the government has gone a step further to recognize them. The first photo there represent actually community health workers when we worked with them in one of the research projects that I'm going to talk about around 2014. So today you can see the community health promoters. The government has recognized them. They have been given additional kits, so they are able to serve households. Why is this level so important? This level is important because a community health promoter knows members of their neighborhood in a unit that they serve. They know which child is not going for immunization. They know which household has a teenager who has given birth or is pregnant. They know a new person who has moved in, probably from even the neighboring country, and the child is less likely to be immunized or to have been immunized. So therefore, investing at this level 1 and where you are dealing with a household is the first level of primary health care that research should see how can we focus at this level. And I'm saying here, the health services provided have significant impact and at a relatively low cost. This is where the community health volunteers will invite or will encourage pregnant women to go for antenatal care, to take children for immunization. But also importantly, they collect data that is actually collected within the Kenya Health Information System. And they are supervised by a trained healthcare worker called a community health assistant or a community health extension worker. So that is the first level of primary healthcare. The second level of primary healthcare is the dispensary. The dispensary has got mainly one nurse and sometimes a public health technician. This is level 2 in the primary healthcare system. I actually just provided that dispensary. This is a dispensary from my village. A typical dispensary will be probably of that size in many parts of Kenya. So the services that are provided in this dispensary include immunization. Immunization for us is a very important service because we know that actually infant mortality has been reduced greatly by increased immunization coverage. So providing immunization for children under 5 is done mainly at the dispensary level. Antenatal and postnatal care, family planning, treatment of minor illnesses, and health education and promotion. So this is level 2 of the primary healthcare system. Therefore, we are saying in our setting, the health services provided here are a significant impact at a relatively low cost. So even when you look at the human resource, if we invest at this level of primary healthcare, then we can be able to impact on health of the communities. This because health of the community is not impacted at the sophisticated hospitals that many people cannot reach. So that is the level 2 of the primary healthcare system. The next level is the health center that I said would have a maternity wing. So we are saying that global health should look at investing research in the area of primary healthcare. Why? Because we are able to, it has got a number of benefits. Number one, it is services provided are high quality, low cost, and cost effective for people and majority of the communities. The primary also healthcare system investing on it or through research will support more equitable distribution of health services and reduce health inequities in populations. The primary healthcare system, as I showed level 1, it serves as a place of early warning for epidemics. As I said there, this is where the community health volunteer knows a child from the neighboring country who has come, who is likely not to have been immunized, outbreaks like cholera that we are seeing today. So this place is very important because we are able to detect epidemics in good time. The primary healthcare system also empowers individuals, families to be decision makers about their health. The other thing is improves access through appropriate health services. And targeted investment in primary healthcare amplifies efforts to improve health in the continuum of care from birth to old age. Therefore, that is what we mean by primary healthcare from an African context or in our context. And therefore, investing in this level becomes a very critical thing. I want to talk about a good example of our previous research that we have done at the primary healthcare level. Some years back, I was part of the team that through funding from DFID, and researchers from the London Knowledge Hub and the University of Oxford, we implemented a research focusing on community health workers, the ones that I've said at the moment we have in Kenya, we have recognized them further, and we are calling them community health promoters. This was back actually 2014, 2016. Back then, very few people were using WhatsApp or were using even smartphone. But through a participatory approach to research, we were able to work with community health volunteers and develop a mobile intervention through a participatory method that enabled them to go to a household and assess child developmental milestones. So an app using a mobile phone, whereby now the community health workers would normally have their routines because they have targets to cover. As I said, that they are not in formal employment. Currently, they're getting a stipend, but then they were not even getting any stipend. So during their routine, they were now able to go to households with children under 5 and input data through the mobile phone and assess the child developmental milestones. So the app had got information that they were required to input. Then after that, after inputting the child gender, date of birth, etc., asking some information, is a child sitting, is a child doing ABCD, the app was able to calculate and provide some general summary whether the child is within the required milestone. But importantly, this information was transmitted to a trained nurse who would be able to verify. So this is how the app was working. So you can see that we will have the community health worker. Then we will have the community health extension worker. Through this app, because community health promoters or community health workers, as they used to be called, are trusted members of the community. After a number of times they have visited household, done this activity, household members started approaching them just separately, saying, "Oh, tomorrow, please pass by my household. There is a child I would like you to assess." So through this, members of the community were able to, or of the household, were able to disclose that they have children in their household that they have not declared, or they don't even take them to the health facility, simply because these children were disabled. Many of these children had either cerebral palsy. We would never have known that these children existed in back rooms of households were it not for this work that is going on at the primary healthcare level. So this intervention led to increase in the number of referrals of children with child developmental milestones. This is simply because families feel stigmatized, but also ashamed of these children, and they tend not to take them to health facilities. So it also made the work of community health workers and their supervisors more efficient, and also the supervisors got to know what is really happening at the community level. So we were then able to develop a toolkit that was used for the next part of the project. So this is a very good example of work that can be done at primary healthcare level, because it impacts at household level, it impacts at community level, and it impacts to majority of the populations. So when we talk about primary healthcare in our setting, we are talking about low cost. We are talking about the household level that is less likely to meet that very skilled, that specialist who is based at a big city with, extensive expertise, but it is unlikely that members of the community would get access to that. So for us, investing on research that is going to impact at the primary healthcare level has got the greatest impact in advancing health, in achieving lasting health change, and also generally in impacting global health. With that, I want to stop there so that we can move to the next stage of this presentation.